All right, everyone, we'll go ahead and get started. Today's chapter is actually over, it's a continuation of the human body. So this is part two. We'll talk kind of more gross anatomy on this one, the musculoskeletal system, those things, and then we'll move into the respiratory and cardiology, and then neurology, and then GI section of this chapter. So again, there's still a lot to this. I want to clarify though, this lecture is not gonna, you can't just listen to this once and understand this. So this takes a lot of work. You have to read your book, maybe use some flashcards, look at anatomy models. It's going to take a while to be able to get all this. I know how overwhelming this seems. So basically, some of these are going to be definitions, so let me just read them to you, right? An organ is composed of at least two kinds of tissue organized to perform a complex task, right? So like the brain, it's composed of multiple different tissues that does a function, right? And that's just an organ, right? And then an organ system is when those systems work together to perform as a team so, an example of an organ would be the brain, and an example of an organ system would be the nervous system, right? So that's the brain, the spinal cords, and the peripheral nerves. So it's a lot of things put together. So that's kind of the example. And, they want you to know there's 12 major organ systems, okay? So we're going to jump into the skeletal system. For whatever reason, I've seen this pop up on quizzes and exams to where they'll want to know the difference between like ligaments, tendons, and cartilages. So it's kind of strange what they do. But of course, the skeletal system has a lot of roles, right? It gives us our posture, right, to where we can stand and walk, and muscles attached to bones that allows us to move. But also keep in mind that the skeletal system protects us, right? So our skull protects our brain, a very important part of human life, right? And the rib cage protects the heart and lungs, again, a very important part of human life. And it's not by coincidence through whatever you want to believe, evolution or our makers, that these are protected very well. The most vital organs are protected with extra bones. So bones do provide protection, they provide structure, they provide stuff for muscles to attach to allow movement. So they have a lot of function, okay? Um, so ligaments, right? And I'll just zoom in on this real quick. So, oh, I don't maybe need to do that, but ligaments, these bind bone to bone, okay? So ligaments bind bone to bone. And so you can see we have, ligaments all up here in the wrist, right, that bind all the carpals together, and that's ligaments, okay? Now, tendons, for example, will bind a muscle to a bone. So like right here, this looks like the bicep. It's connecting, bone here to bone here. So they're connecting two bones that allows for a connection. Because without that, I mean, bones wouldn't move. So muscles move bones, and so that is a distinction they want you to know. I'll say it again: ligaments combines bones to bone. Tendons combine bone to muscle. You might have had tendonitis at some point in your life from overuse, whether it's lifting weights or carrying a child or whatever. And it would make sense that tendonitis is related to muscles and bones. So that's one way you could look at it. And then lastly, it's worth knowing that cartilage will cushion between the bones. So this becomes pretty, there's cartilage here and here. This becomes really important in like load-bearing sections of the body, like the knee, the hip, the spine. So load-bearing areas, especially the feet, we tend to see this, like pathology related to like knee cartilage erosion, right, or osteoarthritis. We see that a lot, and we hear that a lot because it's underweight from the load of the body, the axial skeleton. So that's just kind of worth knowing. Okay, cartilage is like a cushiony stuff. Now, I want to point something out. These tendons, sometimes you can palpate them. So like, it's pretty easy to palpate a tendon. In fact, I don't have my reflex hammer at my desk right now, but you've probably been to the doctor office where they go banging on your tendons, right, to test reflex. That's what they're hitting. They're trying to hit a tendon and elicits this reflex response normally. So that's kind of what that is, okay? Now, moving forward, bones are classified according to their shape, okay? Not necessarily their function, but their shape. So long bones inherently are long, right? So that's your femur, that's the big one in your thigh, or your tibia fibula, right? That's like your shin bones, right? There's two bones down there, right? And your ulna and radius. So your ulna is going to be on your pinky side, and your radius is on your thumb side. And how you know that is we check a radial pulse on the thumb side. So that's where the radius is located, right? And then the humerus, that's, your arm up here near your bicep and tricep, or the bone up here near your bicep and tricep, okay? So the short bones, these are going to be in your wrist and ankle, right? The metacarpals, carpals, tarsals, metatarsals, right? So the carpals and metacarpals, these are your metacarpals, right here, and then these are your carpals, and then your tarsals and metatarsals, right? That's going to be like your foot bones, not your toes, but your foot. So then flat bones, we see these in the skull. Obviously the skull's flat. The ribs, fairly flat if you actually see an actual rib. Um, they don't necessarily look like pork ribs or beef ribs. They actually have a shape like this. So if you were to cut like a rib in half, they tend to look like this, right? And there's actually a neurovascular bundle running beneath every rib to where we have like an artery, vein, and nerve below every rib. So they kind of are more flat than you might think. So don't, be chewing on a baby back rib and thinking, oh, this is what ribs look like. Kinda, but not entirely, okay? Now, the sternum, right? So that's the bone, the breastbone right in the middle of your chest. And your scapula, I know, spelt weird. I didn't come up with it. That's the little triangular bone in your shoulder blade. Okay. Now, irregular bones, they didn't list examples on here, so I added these. But these are like obviously going to be irregularly shaped bones. So like the vertebra, which are the bones in our back. Um, let's see, the ethmoid, sphenoid, hyoid bones. The ethmoid and sphenoid, these are bones up in your skull. I'll show you a picture later on in the lecture. Your palatine bones and your inferior nasal concha. So like these are bones that are in your face and they tend to have a little bit of a weird shape. That's why they're weird, they're irregular, so they're irregular bones. So the reason I'm telling you these and the reason these are on the slide is because again, I tell you this all, I sound like a broken record. These are occasionally tested, right? They'll ask you, what is the long or which of these is a long bone, right? And they'll list out femur, you know, scaphoid bone, or they'll just name out a bunch of different bones, and you'll have to know, oh, the femur's a long bone. So that's how that's usually tested. Okay. Or they'll say someone has like a gross deformity to the right thigh. What bone is likely broken? And they won't list femur as the answer. They'll say it's a long bone. So that's how that could be tested. Now, I will talk a little bit about bone anatomy. It's really not too complicated. Okay, so what could be a little complicated about this is the fact that they have different names for these. Okay, and it's kind of annoying, but that's what we got to deal with, right? So the bone shaft itself, right? So this part, right? The bone shaft is called the diaphysis. Okay, so that's the bone shaft, diaphysis. Okay. And the bone in is the epiphysis, right? So that's obviously what they're pointing to here, right? This is the epiphysis, okay? And the metaphysis is this little area right here. This is kind of where your growth plate's located at. This ends up sealing up and not doing anything after puberty. But the reason this could be relevant is if someone has a break in their growth plate, the metaphysis, then they could have stunted growth on that long bone, so or any bone, but on that bone. So that's why it becomes a little bit more relevant. You see this occasionally in children, but children don't break bones very easily because their bones are a lot more flexible. Old people tend to break bones. If a child does break a bone, you might consider child abuse occasionally, especially with funky stories. Anyways, going back, that's long bones. So let's just zoom in on this and talk about some of the anatomy that's labeled here, okay? So we have this hyaline cartilage. Remember, cartilage is that like spongy stuff at the on in between bones that cushions. It's when I say spongy, that may not be the best answer. It's cushioned, okay? It's very cushioned. It holds a lot of water in it by design, so it cushions on bones. And as we age, you've probably heard people groaning about their joint pain. A lot of times that's from cartilage erosion, okay? In fact, if you want to know if obesity is the most common cause of osteoarthritis, right? So if people having wear and tear of their bones, it's because of obesity usually. Almost always, actually. So it's obesity. But so if someone's obese and they're overweight, this gets worn down, right? So the sponge there, or I don't need to call it sponge, the cushion there will get destroyed from the weight. It's kind of intuitive, okay? Now, we'll ignore this for now. I'm going to come back to that area. But inside of a long bone is this thing called the marrow cavity. And in there is a tremendous amount of blood flow, okay? So there's a lot of veins and arteries, and our red marrow is in there. And what does red marrow produce? It produces red blood cells. So I'll say that again. Red blood cells are produced in the red marrow of long bones, okay? So that's where we get our red blood cells from. And so it's very vascular. And the reason I'm telling you this is in paramedic school, we teach our students how to do something called an intraosseous. And if you break down the word intraosseous, intra, within, osseous, a bone, we drill a needle into the bone like a sheetrock screw, and we can give IV fluids and medications through the bone canal. It's that vascular, and it works the exact same way as an IV. I just use a gun to drill in a needle. So that's kind of a clinical tie back into this. So lots of nutrients, a lot of blood flow going through bones. And the other reason that's important is if someone snaps their femur, it will bleed a lot because there's a lot of blood flow going through the femur. Not only that, there's arteries wrapped around most long bones. There's an artery wrapped around it. So with that, just know that the long bones have a rich blood supply, and when they break, they can bleed a lot. So, and you can have like this thing called compartment syndrome. Now, moving forward, there's this thing called the periosteum. And what the periosteum is, this is like the outer lining of a bone. It's kind of random, but the periosteum is responsible for bone regeneration. So, if someone snaps a bone, right, like breaks a bone in like a car wreck or something, the periosteum is responsible for the repair. Okay, the cells that fix it are there. So now there's two main types of the bone itself in long bones, right? There is the compact bone, and that is this area right here. Excuse me. It's the like actual hard structure of a bone. Very, very hard calcified areas that are hard. And then there's the spongy portion. And this is, I'll change colors here. This is obviously the honeycomb-like structure of a bone is there by design because it reduces the weight of the bone while still giving structural support. So if your entire long bone was this big old chunk of calcium and minerals, that would be extremely heavy. But if you've ever felt a real skeletal bone, which you probably haven't, they're actually fairly light. Like we do this in medical school, and I mean, maybe if you hunt and stuff and you've picked up a dead animal's bones, they're very light. And that's by design. It's because there is this spongy structure within the bones called trabecula that will, or trabeculae, depends who you ask, that will provide the support to a bone. So it's kind of worth knowing, okay? Now, moving forward, I'm going back over here. Whoop. We talk about joints really quickly, okay? So again, this right here is connecting a bone to a bone. It's connecting the fibula to the femur. So what is connecting those two? It is a ligament. Okay. Now, an example, contrary to that, is what is connecting this bone, the patella, to the tibia. The patella is the kneecap. It's a tendon. Okay. So, oh wait. Yeah, wait, that's right. Yeah, patellar tendon. Yes. This would probably be a better example. That is a muscle, by the way. What would be a better example is like the quadricep, which is like the edge of the thigh that would connect to the patella. That is, again, muscle into bone is tendons. So you got to know those. I know, weird. I don't come up with these. Now, moving forward onto this side of the slide, they want you to know, again, that at the end of long bones especially, there's cartilage. Cartilage is this cushioned stuff with a lot of water in it, typically, supposed to, that will cushion bone on bone, okay? When bone on bone rubs on each other, it causes pain because then it causes degeneration and it causes wear and tear. So that's why they keep telling you the same thing, right? Cartilage, when it's destroyed, it doesn't regenerate very well because it's fairly avascular. There's not a lot of blood supply to cartilage. So it's really hard for it to regen, okay? If it ever does regen, usually it just doesn't. So moving forward, bone ends at a joint are held together by a joint capsule. So we see this in the shoulder and in the hip and to a little degree in the knee, to a degree in the knee, of course. But, you know, they kind of want you to know like the difference between a ball and socket joint. So a ball and socket joint is, as you can imagine, a ball within a socket. An example of that would be like the shoulder joint and the hip joint. Those are probably your best ones, best examples. And then a hinge joint will be like your knee and your elbow. They're on a hinge. It's just a hinge. That's all it is, okay? Can't do a lot of left to right because hinges just open and close, right? Compared to a ball and socket, right? There's a ball inside a socket, so you have a lot more range of motion, okay? Now, the axial skeleton versus the appendicular skeleton, okay? The axial skeleton, so the world sits on an axis, right? Like it's this line. Well, it's the same thing for the body, right? So the axial skeleton is this straight, is this. Okay, that's the axial skeleton. And the appendicular, or actually, I'd have to think about this. I don't want to misspeak. I'm pretty sure it doesn't involve the feet. And this is going on YouTube, so you tell me. I don't want to misspeak on that. But I can tell you the appendicular skeleton is everything off of the axis. I really think the appendicular, let me just tell you what I think it is. The axial skeleton is this, and the appendicular skeleton is everything else. So the axial skeleton is the neck, back, head, okay, on an axis. And I'm pretty sure the appendicular skeleton is the legs, arms, girdle, everything else, okay? So the skull, and I hate to just be reading this to you, but at some point you just have to sit down and start memorizing these things and looking at different pictures and lectures on this. So bear with me. But you know, the skull is occasionally called the cranium, or really, the skull itself is the whole head, but the cranial vault is where we hold the brain. Okay, so that's what they're outlining here, right? The cranial vault, that's what we're holding the brain in. Now, there are different portions of the skull that are occasionally tested, but they're fairly intuitive, right? So the frontal bones and muscles of the head are in the front, right? The parietal section is back here. The occipital section is the back of your head. I'll say that again. The occipital section of the head is the back of your head. I would know that. The temporal section is the temporal, like right here. You've probably heard of that. And oddly enough, kind of a fun medical fact, the reason it's called temporal is because that's one of the first places you get gray hair and balding in both men and female women. So temporal means time, if you don't know that. So it's one of the first places you can see age. Shout out me, I have a receding hairline. But that's why it's called the temporal bone. Now, the medical significance of the temporal bone is that it's extremely thin. There's a pathology that happens here called epidural hematomas, where there's an artery that runs up underneath here called your middle meningeal artery. And when people get punched or get a blow to the temporal bone of the head, you can break that artery and it causes this very severe brain bleed that's rather lethal. And again, if you were to look at an actual human skull and cut one open, the thinnest part is right here. It's called the pterion, but it's spelled weird, P-T-E-R-I-O-N. It's called the pterion, and it's very, very thin there, okay? Now, moving forward, you're going to notice these lines. Those are called sutures. That's where the brain fuses together. They're like a suture where we fuse skin back together and suture their skin. So this is where the brain fuses together. Let's see what else we have on here. So the zygoma, right? So that's here, or here really. And then this is the maxilla. I'm sorry, the maxilla is here. This is your zygoma. So your zygoma is like kind of like your cheekbones, and your maxilla is your upper portion of your mouth. Your mandible is your jaw. This area right here is called your TMJ, or your temporomandibular joint. Reason it's mentioned, occasionally there's pathology here. Usually people that talk too much, chew too much, old age, whatever, they'll get popping of this. It'll cause pain, okay? The mastoid process, that's the area behind your ears. You could probably feel it right here, mastoid process. And your orbits. I'm going to talk about orbits coming up, but that's the skull, okay? Let's move forward. So the cranial vault, which I was just talking about, it consists of 8 bones. I don't think that's extremely important, but you have to understand the skull is designed, the cranial vault is designed to protect the brain. The brain itself is in a real human, right? So if you go to a cadaver lab and take someone's brain out, it's preserved in formaldehyde, so they're very stiff, right? But the brain itself, if you were to take the brain out of a living person, or a freshly dead person that hasn't been preserved, it's so soft it would collapse on itself. So I think people think the brain is a lot more rigid and structured than it is. It's not. It's very, very, very soft. So again, if I took your brain out and set it in my hands, it would collapse. It would not be able to hold itself together. It's that soft, very fatty. So that's something to consider And so, since it is such a soft and delicate structure, we have all these things that God gave us to protect it, right? Like our meninges and the skull and cerebral spinal fluid, right? That kind of cushion the brain itself. And when that cushion gets violated from head trauma, then we end up with brain pathology. The brain gets damaged, okay? So, I told y'all the bones of the skull are sutured together, or when they fuse together, that's called a suture, okay? And in newborns and infants, really, there's these thing called fontanelles. Okay, and that this is a newborn skull, by the way, not an adult skull. So it's called the fontanelle, and what it is it's this area right here. And so if you ever felt the top of a baby's skull right about here, there's like a divot and like a dip, and what that is the fontanelle, the interior fontanelle of that. And so we use this clinically to A, look for dehydration, right? So if it's like at a deep dip, then you might think, oh, wow, they're dehydrated. Okay, that's one test, not very specific. But the other way we use the fontanelle is for shaken baby syndrome and meningitis. So shaken baby syndrome is where someone shakes a baby and causes kind of scrambles up their brains. And so this soft part of the skull that hasn't fused together yet, the anterior fontanelle will bulge. Okay, so you can see that in shaken baby syndrome. You also see this in meningitis. So this little blue area on your slide right here, that's it's really not blue in real life, but that can become infected for very simple terms. It can become infected, and that's a condition known as meningitis, right? The meninges, itis, so meninges become inflamed, right? Meningitis. So it's just something to kind of know. I guess I'm just kind of throwing that out there for you. Okay. Now, the floor of the cranial vault, we occasionally see pathology here where people get like a basilar skull fracture, right? And it produces this clinical sign called battle sign, right? To where you'll see raccoon eyes and bruising of the mastoid process. So it is a pretty, and bleeding out of the ears. I've only seen this once. A car fell on a guy's face when he was changing, like doing some engine work. He was up on a cheap jack, and the jack fell, killed him. But you saw like where the blood was already pooling, where he had a basilar skull fracture, like smashed his head like a watermelon. So, anyways, going back, this can snap sometimes, and it produces a predictable thing called battle sign. We'll cover that probably more in head trauma. But there's different parts of this, and really, I wouldn't spend a whole lot of time memorizing the bones in here. The big ones, I'll tell you, the foramen magnum. This one right here. Foramen means like an opening, and then magnum literally, like, obviously means large. So it's the big opening. This is where the brainstem spinal cord kind of shoots out through the bottom of the skull. Um, and then let's see the I don't know, the sella turcica right here is abnormally large. It's huge. Shouldn't be that big, right? On this is where your pituitary gland would sit. It's really not that. It's I mean, to me this seems abnormally large. I'll just say that from what I've seen on real skulls in most anatomy models. And then let's see. This is that area I was telling you about right here, the pterion, right? This is where I was telling you when people get punched there, it's really susceptible to breaking and snapping this artery that's up underneath there. So, that's probably the bigger, the cribriform plate. This is it kind of connects to it's like right here, right? That's where that would be, like up behind your nose. So if someone like snaps their nose up real good, you can push stuff up through that because it's fairly thin right there. Um, that's probably the big things I want you to know out of that. Okay. Now moving forward, um, there's different facial bones, okay? So we kind of talked about these, and I don't know if you would necessarily benefit from knowing every single last facial bone. Maybe you would, maybe you wouldn't. But there's quite a few of them. They get a little complicated. But again, the frontal bone is obviously the front, right? Like your forehead, and then the nasal bones, right? So your nose itself is made out of cartilage, but there are some bones up here, okay? And then this is your zygomatic bones right here. The tips of your cheek. That's called your zygomatic process. You'll notice the word process is kind of things that come to a point for the most part. Like mastoid process. This almost comes to a point back here. So process is kind of like where it comes to a point. Let's see what else we have on here. I told you this is your maxilla, your upper mouth, right here, and this is your mandible. Okay. Um, you have a bone in the back of your throat and the roof of your mouth called the palatine. Um, That's really probably the big ones I want you to know. Yeah, good enough. Now, the orbit, we see this a lot. You've seen someone with a broken orbit. So the orbit's your like kind of your eye socket, and it protects the eye. Okay, and it's by design that your eyes are resected to where when water runs down, you don't actually get water in your eyes. It kind of like pulls over your face. So that's by design, of course, and it also keeps debris out and stuff like that. The sun, it's by design. Now, um, there's a lot of blood vessels, nerves, and fat up in there, and like cushion that protect your eye. But occasionally, patients will get what's called a blowout fracture of the orbit. Okay, really, it's technically called a blowout fracture of the orbit. Now, what happens is in a blowout fracture is the floor of the orbit's very thin. Okay, so like this portion of my eye is very thin. So when I get racked in the head, it'll blow the floor out. So it's a blowout fracture. Well, the clinical significance of this is your eye, especially your muscles, your inferior oblique, can get caught up underneath that muscle and become entrapped. So the patient has a hard time looking up or looking with that eye when those muscles get entrapped up in the orbit, blowout. And so that's kind of worth knowing, okay? So let's see. Oh, and that's what I'm showing here, right? Guy with a black eye. And you can see right here, right? Let me get a better color. Like the floor has blown out, okay? And so the muscle and portions of the eye and nerves and all sorts of stuff will go up into the sinus, and that's obviously not good. This is like emergency. So, sometimes you have to have surgery to free this entrapment. It's a big deal when this happens, Eyesight's pretty precious. So, bones of the nose. So the nasal cavity itself, it's got several facial bones. Um, the nasal septum itself, again, it's cartilage, but it divides the left and right nostril. I don't know how to say about that. I will say this about the nasal cavity. It's extremely vascular. So the nasal cavity by design is to warm air, humidify air, and filter air. So uh, there's a lot of blood in there that will warm, cool air before it even makes its way back. So it warms air. That's important. It humidifies air. There's a lot of mucosa back there that provides moisture. In fact, well, I won't go to that. But yeah, there's a lot of mucosa that will provide moisture. And then lastly, the hairs and stuff in your nose that create snotty little boogers, right? That's filtering air. Okay, so it's keeping large particles out so they can't go back down into your lungs. Okay, so kind of worth knowing that they're pointing out sinuses. You've probably heard of sinusitis, right? To where these can become inflamed for whatever reason, bacterial reasons, and so they become infected. So sinusitis, right? It'll become inflamed, and so we see pathology with that occasionally. Okay, but do know that these bones are hollow and that they can become infected. Okay, I think that's kind of what I want you to know about that. Okay. Now, the mandible and the TMJ joint, we talked about this. Remember, mandible is your jaw, okay, lower jaw, and it has your lower teeth. And the posterior condyle of the mandible, which is like back here, this little portion of the jaw, it articulates with the TMJ joint, the temporomandibular joint, TMJ joint, right? Um, you might know that the hyoid bone floats. You could see this on a test. The hyoid bone floats in the superior aspect of the neck and it supports the tongue. This becomes a little relevant for forensic pathology. You see these in strangulation and hanging injuries to where the hyoid bone will get snapped. So it's just kind of worth knowing. It takes quite a bit to snap this. But you see this in forensic pathology, right? So when someone's dead, they'll go see if like, oh, that was the hyoid bone snapped. That's kind of what that pops up as. Now, the neck has obviously, you have your carotid pulse and you have the external jugular and internal jugular veins and a bunch of nerves that are running through here. But there's a lot of muscle that aid in head movement, right? So um, it's just kind of worth knowing, like your sternocleidomastoid muscle is this one, okay? So it connects um, 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 the sternum with the mastoid process. Um, let's see what else. Remember mastoid process back here. The cricothyroid membrane, that's this right here. And the only reason I'm pointing this out is if you ever watch any Grey's Anatomy or something like that, you've probably heard of like paramedics cutting open someone's throat and shoving a tube down there. It's pretty rare that you get to do that, but what we're cutting is this actual little bitty thing right here and shoving a tube through it. So it's a little thin membrane that's pretty easy to cut compared to, around your thyroid right here. This is actually really pretty hard. It's cartilage, so it's very, it's hard. So it'd be kind of hard to cut through that, but you can cut through the cricothyroid membrane. Okay, the trachea lays anterior to the esophagus. So your windpipe, your trachea takes air down through your mouth and nose down to your lungs. And it's this ringed structure. So it has cartilage and it is rigid. And opposed to the esophagus is not ringed and it does not have structure. So it's very squishy. It's just like a little food tube that collapses. And when you swallow, it opens up and closes back. So, but the trachea always stays as a perfectly round thingy that allows air to go through there, okay? Just that's probably the big thing I want you to know. Your thyroid lies in the anterior neck. Your parathyroid lays next to the thyroid, and they have to do with like endocrinology, hormone regulation, calcium, stuff like that. We'll talk about that in endocrinology. Now the spinal column. For whatever reason, this is occasionally tested. Like, how many bones are in the cervical spine? And you're like, oh shit, I got to remember that. You do. So a really easy way to remember this is, what time of the day do you eat? You're a student, so you probably have to wake up at 7 and eat breakfast. And then you get your 1 hour lunch break at noon. Let me show you why I'm telling you this. All right, so we eat breakfast at 7, then lunch at noon, and then dinner at 5. And then if you add 5 and 9 together, or 5 and 4 together, it's 9 o'clock and you want a little dessert before going to bed. Okay, so if you kind of think of the hours of the day when you eat, maybe not you're supposed to eat that time, but if you think of like hours of the day when some people might eat, that might help you. So we're never going to expect you to be like, where does the cervical spine end and the thoracic spine begin? And I'm not going to ask you to point that out. But what they will say is, how many bones are in the cervical spine? And you're going to have to say 7. How many segments are in the thoracic spine? You're going to have to say 12, right? So, and how many spines or how many bones are in the lumbar section? 5. In the sacrum, 5 again. In the coccyx, which is like this little bitty bone at the bottom, it's 4. Okay, so they want you to know that. Okay, I will have you know that the sacroiliac joint, it's going to be on your quiz. Shout out. Lays right here, and that's where the majority of the weight will lie with your pelvis. Okay. By the way, I look over y'all's quizzes before making these videos and try to tie it together. So, the spinal column, I just explained this to you. I will talk about this. So we have this atlantoaxial joint of the skull, okay? And C1 and C2, one will go up and down and one will go left and right. So the first 2 bones are the atlantoaxial joints, okay? And then further down from there, like 5 more, so a total of 7, is the cervical spine. And the reason that that sometimes they get real hung up on this is because blows to the cervical spine, as you can imagine, are really bad, because virtually all peripheral nerves, not all, but virtually all peripheral nerves are running through the cervical spine. So if you get a baseball bat right here to the neck, you end up with really serious pathology, and your diaphragm doesn't work, the muscle for breathing, or you don't, you become a quadriplegic, whatever pathology it may be, or you just straight up die. So that's why this becomes important. And oddly enough, God didn't give us a whole lot of protection for our neck in relation to how important it is. So the neck is fairly vulnerable to trauma. And that's why, as an EMT, we need to know that. The neck is fairly vulnerable to trauma. In fact, one of my favorite things to do, men listening to this lecture, you should listen. If you're ever making a woman uncomfortable, or if you notice a woman is uncomfortable, by design, they will typically start grabbing their neck, right? And you think about, like, why would that be? It's because it's very vulnerable, and as humans, we know that. So when women are uncomfortable, and men too, but especially women, they will grab their neck. So it's a good thing to know, like, oh, they're grabbing their neck, they're uncomfortable. So maybe they feel unsafe by someone else, or you're making them feel uncomfortable, whatever it is. Just kind of a good body language social cue to be picking up on. People suck at social cues these days in 2023. So anyways, moving forward. Let's look at, so this is like a cross section of the spinal cord, or really not the spinal cord, but like the vertebrae and the spinal cord. So this is the posterior section that I just highlighted. So that's like the back, like the furthest back. And you can feel these spinous processes as you feel down someone's back, right? You can feel those. And occasionally those break, not super important, but occasionally they break. Um, and the anterior portion is where the body of the vertebra lays. So this is like a thick chunk of bone. And within the vertebra, the idea of this is not only like mechanical support of the body of the spine, but within the center of the vertebra is the spinal cord. And the spinal cord obviously carries the central nervous system, and it branches off to the peripheral nerves. So it's to protect the spinal cord. And again, when someone gets in a motorcycle wreck and snaps their back, and the spinal cord gets broke, it does not regenerate ever. The central nervous system cannot regenerate. Nerves can. Neurons themselves can. But so this becomes a problem because they become permanently paralyzed. So again, you'll feel the spinous and transverse processes a little bit, especially on skinny people. If you feel down their back, the spinal cord's in the middle, and then on the back you have the body, and these are like these nerve roots that'll branch off of the spinal cord and go do their thing, whether it's sensation or pain or messaging or whatever they do. It depends. So moving back forward to the thorax. Okay, so the thorax is obviously like the chest, okay, and the back really. And they want you to know we have 12 ribs. Okay. Now, what I want you to know, because students jack this up, is the first rib is up underneath the collarbone, right? The clavicle is the technical word for it. The clavicle is called the collarbone, and that's what this thing is right here. That's the clavicle. It's one of the most commonly broken bones in humans. Okay, we break these a lot, especially like people that fall and stretch out their hand. So, anyways, the clavicle breaks a lot, but up underneath there is your first rib, and in between each rib is a little space, and that space I want you to know is called the intercostal space. I'll say that again. If you feel between your ribs, they're called intercostal spaces. We use this, okay? So it's called the intercostal space. And I told you, if we were to take someone's rib and cut it open, right, there's going to be an artery, a nerve, and a vein up underneath every single rib. And so when someone snaps their rib, it causes an unbelievable amount of pain because there is an actual nerve assigned to each rib that when it breaks, obviously that causes severe pain. So kind of worth knowing. They connect to the ribs. Most of them will end up connecting to the sternum, which is the breastbone. They point out this thing here in the center. You can feel this if you're skinny, called the xiphoid process. The reason I tell you what the xiphoid process is because when we do CPR on people, this commonly snaps off, and you'll break it with chest compressions. And I'll have you know this too, especially on old people. Well, this is a good relation, right? So on an old person, when you do CPR on an old person, I hope one day you get to help someone by doing CPR. It's you don't get to do that every day, so it's kind of a cool experience. When you do CPR on an old person, it's like cracking down on a bag of Doritos. You are going to break their ribs, and it's going to be pop, 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 pop. And as you keep going, pop, like you'll get another one, pop, pop, and you'll just keep breaking their ribs. It's really gnarly. It doesn't mean you're doing CPR wrong, but it's a strange sensation. Everyone's got to try it once. So, but what I'm telling you is the xiphoid process itself will snap off. And it's occasionally tested for whatever reason. The xiphoid process will snap off. So we place our hands here on the body of the sternum, and they may tell you the manubrium, right? Or manubrium, sorry, is this upper portion of the sternum. I mean, I don't think that's super relevant, but anyways, here it is. So, yeah, I mean, that's the thorax, and really the design of this is to protect the heart and lungs. Kind of intuitive, okay? When people break ribs, it hurts really bad. And the hallmark sign of a broken rib is you tell the patient, take a deep breath in, and does that elicit more pain? If it does, probably have a broken rib. Okay, it's a really good sign. Let's see. So the thorax, I was just talking about this. So what they did is they just removed the ribs from this picture. And so what they're showing you is obviously we have two lungs and a heart and all this stuff that branches off. But what I want to point out is the fact that, first off, the heart sits in the center of the chest. Common misconception. The heart sits in the center of the chest. Now, with that said, it is in the center of the chest, but a bigger chunk of it, the left side, sits in the left cavity, okay? So people think like the heart actually sits in the left side. This is my left. The left side of the patient's chest. It really doesn't. It sits in the middle. Just a big chunk of it focuses on the left. We'll talk about that in cardiology. But obviously we have lungs, right? And so right now I want you to take your hands and fill up your rib through the bottom of your rib cage, okay? So pretty much near the bottom of your rib cage is this thing called the diaphragm. Okay, it's spelled weird, it's right here. Diaphragm. Okay. Now the diaphragm is a skeletal muscle that's relatively thin. And so if what happens is when someone breathes, the phrenic nerve comes off the fourth cervical spine. It tells it, I want you to contract. And if you know anything about muscles, when muscles contract, they get shorter, okay? Just like when I contract my bicep, that muscle gets shorter, it balls up. Well, the same thing happens in your diaphragm. So what happens in the diaphragm is when the phrenic nerve says, yo, homie, contract, it gets smaller. And as it gets smaller, it goes from this dome shape to it flattens out. Well, as it flattens out, it creates a negative pressure. So it starts sucking in. It's almost like pulling in like this. And so it pulls down onto the lungs and it creates a negative pressure. Air goes into the lungs. And as the muscle relaxes, it pops back up to that dome-like structure, creates a positive pressure, although albeit it's still a little negative. And then it'll force air out. Okay. So the reason I'm telling you this, just kind of a quick seed to plant. Inspiration, breathing in, is a active process, right? Your brain has to tell your phrenic nerve to send the message out, and diaphragm has to have energy and it has to contract, right? Skeletal muscle, diaphragm, yeah? Now, exhalation is a passive process to where even dead people, if I were to take like someone who's dead and we didn't do CPR on them and push on their chest, you might hear them grunt or groan. You might hear, ugh, because that's air escaping through their trachea, through their glottic opening, right? Their vocal cords. So I'm kind of getting off topic on that, but we'll talk about this, okay? Just know the diaphragm is the muscle that's mainly used for normal respiration. Remember me talking about the intercostal muscles or the intercostal spaces? There's actually muscle between your ribs too that occasionally, especially like in pathology, like people that are having a hard time breathing, will use those too, and that's called accessory muscle usage. We'll talk about that in the respiratory chapter, but I'm just laying some stuff out for you. Now, the shoulder girdle, kind of actually extremely complex. Lots of pathology happens here, but let's just talk about it. It's easy, okay? So your sternoclavicular joint here, right? That's where the sternum and the clavicle, remember our collarbone, that's where they join. And your acromioclavicular joint or the AC joint, that's this one. This is the corner one, okay? Um, and so you have this thing right here. I'll just zoom in on it. The acromion process, right? It's this little thing that pops up to the clavicle. This whole puppy, it breaks often, okay? When people fall and they stick out their hand, the energy's transferred up and snap. It snaps right here. So you see that pretty often that people will break their clavicle. The hallmark of a broken clavicle is they'll hold their arm close to their body. It hurts to lift it away. So they'll be holding it close to their body in a neutral position. Anyways, so that's the clavicle, okay? Also known as the collarbone. I would use the word clavicle. It's more correct, right? More scientific. Collarbone sling. I'm just telling you that because you've probably heard of it before. Now, moving forward. The humerus, we talked about it. That's the long bone in our upper arm. But we have this thing. This is a ball and socket joint called the glenohumeral shoulder joint, right? It's the shoulder joint. It's ball and socket, right? There's a ball and a socket, and it allows for 360-degree motion. Ooh, cool. Now, on your back, you could probably feel this. It's your scapula, okay? The scapula is this little triangular bone in your shoulder. And you don't really see a lot of pathology with this, although I have seen scapula fractures. But let me tell you this about a scapula fracture. If someone breaks their scapula, it was a very, very high energy event, right? Very major car wreck. A bull stepped on them. They got ran over. A baseball bat directly to the scapula. So what I'm telling you is these don't break very often, but when they do break, it was something significant. Okay. This is kind of looking at the posterior angle of it. So this was looking at from the front. This is the anterior angle. This one is the posterior angle, okay? So, just two different angles of the same joint. We see that, if we were to look, if the camera was shooting this way, that would be the lateral angle, okay? So, now, Back to the appendicular skeleton. We're still on this. So we have the upper extremity. Again, this is our humerus. Um, it doesn't break often, but they certainly break. And just know there's arteries and nerves that wrap right around here, mid shaft, and here too, really. There's arteries and nerves all over these things, okay? And they break sometimes, and when they do, it causes pathology, and that's worth knowing. But again, humerus is the long bone, and we have our bicep. Bi means two, right? So there's two muscles that make up the bicep mainly. And then there's three muscles that make up the tricep. Three. Oh. So that's why that is. Okay. And then let's see. The condyle, this is your elbow. So if I were to ask you, student, where is your lateral condyle? It's the outside. It's the outside of your elbow. Okay. And the medial condyle, wapa, it's the inside. Okay. It's right there. I don't like touching it. But that's the inside. Okay. The old cranium process, that's this piece right here. Let's see. Remember, the radial bone is where we check a radial pulse, and we check a radial pulse on the thumb side of the patient, okay? So this is our radius, and our ulna is outside, okay? You don't see a whole lot of, I mean, you do see a lot of radial ulnar fractures. In fact, I saw a lady last week in the clinic. She told me, she's like, I really feel like my arm's broken. I'm like, oh no, you can move it. You know, I don't think it's broken. We shot an X-ray. Holy crap, it was actually broken. So we called her, set her up. But I wouldn't dismiss it. I mean, we X-rayed it. But what I'm telling you is, um, the reason I'm telling you this is when a patient has a bone fracture, especially long bones, they can point to it, and that's called point tenderness. So when the patient can go, my arm is broke right here, like this poor lady did, and because I tell her point with one finger exactly where it hurts, it's a good sign. That's called point tenderness. Now when they say, well, this whole area hurts, that's not point tenderness. So point tenderness typically means there's a fracture, and it's the strangest thing. It's like they have x-ray vision. They can point and say it's broken right here, and they will point exactly to where the x-ray is going to show it's fractured, okay? So kind of, a clinical tie-in that people do break bones, of course. And another word that I'll throw out now, we'll cover this in orthopedic trauma, is the word called crepitus. I'll say it again, crepitus is when two broken bone ends rub on each other. So like when you're doing CPR, you'll feel crepitus, okay? When someone has like a grossly broken bone and you start manipulating and splitting their arm, you'll feel the crepitus. It's absolutely disgusting. It feels like worse than nails on a chalkboard, but sometimes it's what you got to do. So you will feel crepitus, okay? And that's when two bones rub together, broken bones rub together. Okay, of course, yeah. So the radius joins with the wrist bones. In fact, the ulna actually doesn't really join with the wrist bones, also known as the carpals. So the radius, again, the thumb side, will join with the wrist bones, and then you go to your carpals, which are regular shaped bones, and then you'll go into your metacarpals, and then your phalanges. Okay, so it's worth knowing thumb, index, long, not your middle finger, it's the long finger. Ring finger, small finger, not your pinky finger, it's the small finger. So it's worth knowing um, those names. Phalanges, real sophisticated word for the fingers. Okay. Um, Trying to think. Yeah, that's kind of these are kind of obvious. I don't have a whole lot to add on some of these. I will say that we get arthritis in these a lot. Okay, so we see this a lot in older people. It's a wear and tear disease usually, unless it's an autoimmune, which is rheumatoid arthritis. But osteoarthritis is very common. So you get swelling of these. Like you'll see, like if you were to go up to your grandma and look at her hands or grandpa, you're going to notice that these are swollen and like little balls on their joints. That's osteoarthritis. Okay, it's a wear and tear disease of the joints, and you see it in the hands a lot, in the knees, but you'll see it easily in the hands, I should say. All right, the pelvic girdle. So, um, this is your pelvis, okay, right? Again, it takes a lot of energy to snap someone's pelvis. So if someone does have a pelvic fracture, whether it's an open book or whatever, it takes a lot of energy to do that. So be aware of that. And a lot of important stuff flows through the pelvis, okay? The main one being the internal and external uh, uh, femoral arteries, right? The internal iliacs and all that stuff. There's a lot of nerves and arteries that will run through there. And on yourself, okay, I want you to find where your femoral artery is, because students really struggle with this, and we actually use this. So not on the person sitting next to you, but on yourself, you can feel in the crease of your groin some stuff. It almost feels like a hose. And I want you to feel on that and find out where your femoral artery is, because we use this in CPR a lot. Because you can feel for that, because sometimes the carotid, if they're like doing airway stuff, there's a lot going on up here. So do know how to palpate the femoral artery. It's clinically relevant. Students struggle with it for whatever reason. If you ever get to do CPR, pull down the patient's pants a little bit responsibly and find the femoral pulse. Okay, it's a really good pulse site to find in CPR. Okay, um, so and if, in fact, I'll tell you, working outwards in, it goes nerve, artery, vein, lymphatics, navel, kind of like belly button, navel. So it's kind of worth knowing the order of those. Might help you. Anyways, this is obviously the pelvic girdle, okay? And so we have this thing called the iliac crest. If you've ever banged that on a tabletop, you know it, it hurts. But this can snap a little bit easier. I mean, you can snap this from a fall. It's not super common, but you could. I've seen that. Um, but remember me saying like an open book pelvic fracture? That's right here where the pubic symphysis will snap, and their pelvis will kind of open up like a book. It's called an open book pelvic fracture. Major trauma when that happens, like big deal, obviously. So this is the ilium, iliac crest, the sacrum. This is the coccyx, right? It's that last four chunks of the vertebra. Doesn't really do a lot down there, but it's there. The tailbone per se. So this is your acetabulum or acetabulum. I've heard people call this acetabellum, and I don't think that's the right pronunciation of it. But yeah, potato, right? So this is where your the ball and socket of the femur will join into this hole. Okay. Now here's why I'm telling you this. Okay, I'm going to draw this out for you. So this is someone's like femur, and then the femur goes down this way, right? What you've probably heard of like granny saying, "I broke my hip." They didn't mean this. Okay. What they actually probably broke, this is very common, is they break the shaft the where the head and the shaft of the femur will join. It's pretty easy to snap right there, and it'll snap off. Okay. So when someone says, "Oh, I have a broken hip," they don't actually mean the pelvis. They mean it's the ball and socket of the femur is where it typically snaps, right here. Okay, so it's worth knowing that. So yeah, it's kind of it on that. This is the femur. It's the longest bone in the body. Ooh, wow. It's the longest bone of the body. Um, if you snap your femur, it takes a lot of energy to do that, but it does happen quite often. We have this thing that I call the closed femur fracture splint, also known as the traction splint. So we use a traction splint to splint the femur. We'll talk about this in orthopedic injuries. And what the closed femur fracture splint, also known as a traction splint, does is, think about this. There's muscle pulling on the femur in both ways. So what happens is when someone snaps their femur, that muscle's still pulling. So you end up with the muscle or the bone being displaced. Well, that causes a severe amount of pain. So what we have to do as paramedics and EMT sometimes is we have to apply traction, and we have to pull it back into place. Well, when we get it back into place, we need to keep it in place. So we use this splint called the traction splint. I call it the closed femur fracture splint, and because it's only used in closed femur fractures. And so that is useful. Sometimes when someone snaps their bone, again, it'll line up on itself like this, and we have to pull traction to line it back up to where it doesn't hurt as bad, okay? So this is the neck of the femur right here. This is where I was telling you when grandma says, "Oh, I broke my hip," they actually mean that. That's actually what they broke. They don't mean the pelvis, okay? It's pretty rare to break your pelvis. And if they do break their pelvis, they're going to tell you, "I broke my pelvis, not my hip." So again, a hip fracture is the neck of the femur. It's where it snaps, okay? Now, yeah, this is your lateral epicondyle. It's lateral epicondyle of the femur, right? So it's the outside portion of the knee. The medial epicondyle is the inside portion of the knee, okay? Now, oops, I went backwards, my bad. All right, so this is just showing the leg. Now, it's worth knowing that the tibia is the actual shin bone. You can feel that. And I've heard people explain this way, and it might help you. What is the more load bearing one? It's the tibia. Okay, it's the bigger bone in the leg. Now, the fibula is a lot smaller. Okay, and it doesn't support much weight actually. It just helps with articulation. Now, the problem with the fibula is will say it's just a little fib. You know, like when someone tells a little lie, they'll call it just a little fib, right? So you might think that it's just a little fib, right? Little lie, little fibula. The fibula is a smaller one. Hope it helps. You know, it is what it is. Now, the moving further down, the tarsals is kind of like the upper ankle area, you know, and then the metatarsals are the like foot, and the phalanges again are going to be just like our fingers, right? The toes. Okay. Now we see a lot of pathology in the ankle because people are clumsy and they will end up dorsiflexing their ankle to where like if this is someone's foot, it goes up underneath them like that, so it kind of twists. And so we see a lot of like ankle pathology and strains and sprains of the ankle. Okay, so you see that, you know, that's very common. I'll mention the patella. I've seen it several times where patients have actually ruptured their patella. It's usually when they fall and obviously they hit their knee first, and that catches their load and their weight. It's very gnarly when this happens. Causes a tremendous amount of swelling and pain. Unbelievable amount of swelling. The lady that I can think of, her her knee, I swear it looked like a cantaloupe. It was huge. And you really have to worry about compartment syndrome when that happens as well, which we'll talk about later. But it was very, very, very painful for her. Gave her a ton of narcotics on the way to the hospital. I felt really bad for her. But just know, you know, people can break their patella. Not super common. What can also happen too is dislocation of the patella. It can go laterally or medially. And so physicians will usually just straighten out the leg and hope that it'll pop back in place, where they'll just manually grab that puppy and move it back to where it's supposed to be. We don't do this as EMTs or paramedics, okay? But know that that happens, okay? It's the kneecap. Patella is the kneecap. Now, the knee, okay. Um, this is complicated. So the knee's a hinge joint, okay? That's not complicated. Easy, okay? Because it can only go up, down. It can't go left or right, right? Can't do 360 like the hip and shoulder can. Now, we have these ligaments called the anterior cruciate ligaments and the posterior cruciate ligaments, and right, the lateral cruciate collateral ligament, right? All these different ligaments, okay? MCL, ACL, you've heard of these things, okay? Well, the reason these are things is because if someone plants and hyperextends their knee, they can tear ligaments, okay? What are ligaments? They connect muscle to bone. So, wait, no, bone to bone. I'm lying. Now, what happens is when they hyperextend their knee, or if like this is someone's knee and they do like a left motion or a right motion, you know, see this a lot in soccer and sports and stuff like that. Football, they get taken out at the knees. They can break these. So we do see this a lot, and in fact, we're seeing this in younger and younger people that are having to have knee surgeries and knee repairs due to sports and sport-like injuries, physical injuries. So just be aware, there's a lot of tendons and ligaments in the knee that work together that have to provide support. The knee actually is an extremely vulnerable joint. Um, I'd say it's probably the most vulnerable joint. Like you see a lot of pathology with the knee just because they're just there's a lot going on down there and they're constantly under load and tension, and it's really easy to fall and, you know, twist your femur versus your tib fib in the wrong direction, and so it causes pathology. So just be aware of that. You know, lots of knee pathology out there. It's a hinge joint. So the ankle, this is your calcaneus, also known as your heel bone. Just, you know, you see this. This is your Achilles tendon. Okay, so I've ran patients that have had their Achilles tendon rupture. I am told it sounds like a gunshot when these pop. People that break their Achilles tendon because it's under so much load. When they snap this, it's extremely painful, as you can imagine, and it is it sounds like an actual gunshot. It's that loud. So, anyways, calcaneus is the heel bone. Um, you know, your medial malleolus, I'll have you know, your medial malleolus. This is your ankle. So if you were to feel on the medial, the inside of your leg, and go down and feel that ball, that's your medial malleolus. Your lateral malleolus is like your lateral ankle, like the outside ankle. Okay. Medial malleolus, you can fracture that. I mean, it gets hit sometimes. I like to think of that as like a scooter injury, someone that's doing a flip or something on a scooter, and it smacks the inside of their leg. So, don't have a lot to add on this. There's a lot of muscles and ligaments and tendons that go down through the foot that provide its structure and its movement. Um, I just don't have a lot to add on that. Yeah, it's nothing super high yield. Okay. Now, real quick, I know this is mostly anatomy. We got to talk about physiology. So, bones protect internal organs, and the muscles enable movement, right? So that's pretty intuitive, right? We've talked about that. Um, and this is weird, but the bones do actually consist of cartilage. It's just a different cartilage from what I was telling you of, like that spongy stuff, cushiony stuff that we have like in our knees and our elbows and our fingers, right? But the bone itself is actually cartilage. And this calcified calcium that we call, it's a mineral called hydroxyapatite. Okay, I know, weird, right? So again, the bones are made up of a different form of collagen. It's type 1 collagen. And this mineral called hydroxyapatite, which is calcified minerals, basically. So bones are a living substance. Don't believe, yeah, you better believe that they are. They're constantly remodeling. So these little Pac-Man guys go in there and clean it up, and these other guys go out there and build out new bone. So it's a constant process through life that bones are a living structure, and they do require blood supply. And if bones don't get blood supply, they die and they will break, and pathology occurs. You see this in cancers and different disorders, vascular diseases. But yeah, I mean, bones are living. So don't think that they're not. Bones are living. Now, we have three different types, main types. Well, really just three types of muscles. Okay? And this is very important to know the differences between these. We have cardiac muscle, skeletal muscle, and smooth muscle. I'm going to give you a quick spiel about these muscles real quick. Now, cardiac muscle, as you can imagine, is striated. So what does striated mean? It's got striations. It's got lines in it. As you can see here, we're talking about this. We're talking about cardiac muscle here, okay? So it's striated, okay? It's important to know. It has automaticity, right? So it can kind of do its own thing, okay? It doesn't like to do its own thing, but it can do its own thing. It can do its own thing. It is not underneath somatic control. So we do not have control over our heart rate, right? I can't think, heart, speed up. It won't do it, right? Compared to I can tell my finger to shoot the gun, right? So it's your cardiac muscle is not underneath conscious or voluntary or somatic control. They all mean the same thing. Let's see. And that's probably the big things I want you to know. Compared to skeletal muscle. Skeletal muscle, like cardiac muscle, is striated. So it has lines in it. It is, for the most part, under voluntary control. The exception to that is the diaphragm. The diaphragm is both under voluntary and involuntary control. What's the diaphragm? It's the muscle used for breathing. So I can tell my body, hey, body, hold your breath. And I can tell my body, breathe faster, breathe slower. But also I can lose that ability, right? So when I sleep, it's under involuntary control. And usually through most of the day, it's under involuntary control. I'm not really thinking about it. Okay? So yeah, skeletal muscle is striated. It is both under voluntary and involuntary control. And it's skeletal muscle, right? Skeletal muscle and the diaphragm. So facial muscles and your arm and your chest and all these things, your legs, they're underneath skeletal muscle control, right? And then the last one is smooth muscle. Now, smooth muscle is not underneath voluntary control. So you can't tell your uterus, hey, uterus, which is a smooth muscle, do your thing. You can't do that, okay? You can't tell your bronchi, which have smooth muscle, hey, bronchi, unconstrict. I need to breathe faster or breathe better. You can't do that. So they're underneath involuntary control. And the reason they're smooth is they're non-striated. So there's not like these obvious lines that run through smooth muscle. And that's what they're showing you down here, right? As opposed to like skeletal muscle, they run in lines like this. And so does cardiac muscle. They run in lines, okay? and they have their own like distinct patterns and stuff underneath a microscope, but I don't think that's super important for you to know. But just know which ones are striated, which ones are voluntary, and where do you find them, and I just covered that for you. Okay, that's how that'll be tested. Now, I'll quickly run through these muscles. So if you go to the gym, you probably know all these because you usually target muscles, right, at the gym. So the traps or the trapezius, these are the ones right down here on your shoulder, right, doing your little shrugs, okay? The deltoid, it's the external ball right here, okay? Everyone wants big deltoids, I do. The tricep, I told you, is made up of three muscles. It's on the back of your arm. The bicep, it's the front of the arm. Okay, the pectoralis major, pectoralis minor, this is your chest. Your chest does have muscle in both males and females. Okay, this has to do with pushing motion like that, like a bench press. All right, you're targeting the chest. Okay, there's the major, minor, pectoralis. I don't think you need to know the difference between those. Let's see, the rectus abdominis. Okay, so we have abdominal muscles, and then on the exterior we have the obliques. Okay, so this has to do with being able to sit up, and it also maintains body posture. Okay, and keeps your spine erect. Um, Over here, we're on this muscle, right? The latissimus dorsi. These are your lats, right? These are like pull-ups. So this is the area up underneath your arm and your back, and it's a fairly large muscle that helps with pulling, right? The gluteus maximus versus the gluteus medius. Who cares? This is the butt. Okay, this is this area right here. So this is the butt. You do need to know gluteus maximus, gluteus medius equals the butt. Okay, got to know that. The quadriceps, quad four, right? There's four muscles that make up the thigh. Okay, and we use that. The anterior tibialis, we don't really use this. It's used for anteroflexion or the dorsiflexion of the foot. You don't really use that a lot, but it's there. But the gastrocnemius, this is your calf muscle. Who doesn't want bigger calves? I do. So the gastrocnemius is the calf muscle. The gastrocnemius is the calf muscle. So do know that. It's like a very brief overview of major muscle groups, but I mean, if some of these surprised you, color me surprised because these aren't like very novel or new or like these are. I don't know. I feel like they're pretty common sense. So this is the last slide. Hang with me. Now, um, we talked about in actually the last section that we have to have ATP for cells to do their job, whether it's your brain or your eyes or my tongue or whatever. But the muscle itself uses a fairly large amount of ATP. Okay, so muscle fibers, for the most part, have just a fairly short-term amount of ATP. Okay, and remember, ATP is a thing we use for energy within the body. It's like a currency of energy. And so ATP has to be regenerated as you use it. So as I'm at the gym or sitting here talking with my hands as I do, muscle or ATP has to be regenerated through glycolysis and whatever pathway to go through the Krebs cycle and through electron transport chain and oxygen and all this stuff to produce ATP, okay? Well, that happens in muscle, okay? So for the most part, ATP for the most part, is regenerated in the muscle. This is why your muscle has glycogen stores so we can get glucose, okay? This is also why muscles have a high amount of mitochondria, depending on the muscle. That way, and blood flow and blood stored in it, that way we can easily access glucose, and that way and oxygen, and that is so it can make its way down to the electron transport chain within the mitochondria, the powerhouse of the cell, and produce ATP through the electron transport chain. Okay, wow, big review, right? It's a lot to say, but that's kind of why why that exists. Okay, so know that muscular contraction requires ATP. I'll tell you this. Oh, it's right here, right? So oxygen is required for the breakdown of the glucose in mitochondria, right? That's aerobic metabolism. And I didn't tell you in the previous lecture, but sometimes if someone wants to be real sophisticated, they'll call this oxidative phosphorylation, right? Same thing as aerobic metabolism. That's what's happening in the electron transport chain. So oxidative, right? And you're phosphorylating. You're taking ADP to ATP, the better form of energy. Okay? So our sensation of fatigue comes when we don't have oxygen for our for the cells. Okay? So our muscles get fatigued as we are working out in the gym or doing whatever. They'll get fatigued as they start running out of oxygen, and we interpret that lack of oxygen as fatigue. Okay? Yeah, and we'll kind of end on that. So that's it for this lecture. If y'all have any questions, let me know. Again, I know this is a lot, but in the next one, we're going to start jumping into the cardiovascular respiratory systems, and those are really intense. So, I say this all the time. One of the greatest tools you have is your own body. Okay, so you could go to the gym and be targeting your traps and knowing, oh yeah, it's my trapezius. Or I got desperate in medical school, and I started. There was a time where I drew out the different. We had to know all like the nerves and stuff, um, different nerves on my hands and stuff. And it wasn't at school, but I was doing this like on the weekends to where I was like, every time I look, I'd have to know like, oh, this is the medial nerve and this is the ulnar and like what the distributions are. I mean, it's what you got to do. So do know that you always have your body and the National Registry can't take that away from you. So, okay, that's it. See you on the next video.